Hi guys, Dr. Gillard here once again. Hope everybody is doing well and staying healthy. Let's do our CVPP lab for today. This is week 6. We're going to start the cardiac examination today. These are brand new slides. I used to have these in PowerPoint form, so I literally made these about 2 hours ago. So forgive me if I stumble a little bit because I've never been through them before. But here we go. Cardiac exam. So where are we going? What's the order of the cardiac exam? Inspection. Not auscultation. No, that's for the abdominal exam. Inspection, then we go into palpation. Then we go to percussion, then auscultation. And palpation, for the cardiac exam, it's only two components. It's looking for turbulent blood flow with your fingers, all right, or really with your metacarpophalangeal joints. And that's called looking for thrills, not bruits. Bruits, that's an auscultatory sound. You can only hear bruits with a stethoscope. It's the same turbulent blood flow, but you don't say, I'm feeling for bruits. No. And you can bet that's going to be one of my questions. By the way, these slides, no stars because I just made them. So anything on these slides is fair game for the test. So my star rule does not apply to these slides. Okay, so we're looking for thrills, turbulent blood flow. The other thing we're assessing for is the apical impulse, and I'll explain that when we get to it. With regard to percussion, we barely do any percussion in this exam. In fact, some board books say don't do it at all. But the only thing we need to percuss still is for the lateral border of the heart, the left lateral border. And we're trying to check for an abnormally large left atrium, indicative of left ventricular hypertrophy. We have a better way to do that, and both of these ways are not very accurate. Patient will be in a gown. Really, though, to do inspection, how can we inspect the chest if it's covered by anything? For a guy, it's okay. You can take off their shirt. I think you can still do that in this day and age. Can you? I don't know. Maybe you can't anymore. But for a female, you don't want to ask a female patient to take off her shirt. I don't think as a chiropractor. Maybe as an MD, you can do that. But maybe they can wear a bikini top. I don't know. You probably should stay away from inspection. I'm not sure how they're going to handle that at the boards. Because if you have them in a gown, you can do all the other stuff, but you can't do inspection. So I'll let each one of your boards figure out what to do with that problem in this day and age. All right. Patient positioning. For most of the exam, they will be seated. They'll be supine, face up on a table. There are some special maneuvers. They're still going to be semi-supine today. But when we talk about auscultating next week, there are some special maneuvers where they will be seated. Today they'll be supine or possibly semi-laying on their left side, which is called the left lateral decubitus position. We'll get to that one when the time comes. Doctor positioning, you should always be on the right. All the time stay on the right. Bates, which is one of the chiropractic board books, allows you to auscultate on the left side. I'm not sure. I guess they don't want you reaching across. You're really not reaching across that far. I think everything. Seidel, the other board book, says do everything on the right side. So I think you stay on the right, you'll be good to go. Okay, inspection, as I said, without a bare chest, I don't know what you're going to be able to do, but I'll tell you anyway. If you do have a bare chest, what you're inspecting is called the precordial region. And you're going to be looking for various precordial movements. What is the precordium? Precordium, here's an anterior view of the chest. It's basically the middle third of the thorax and favoring a little bit to the left side. It's basically where the heart and great vessels are. That's the precordial region. And of course, there are some zones that you need to know, and we're going to look in and we're going to palpate in. There's the apical region, which is really important. That's in the mid-clavicular line. There's the clavicle. You split it in half. The apical impulse is right here in the fifth intercostal space. So this is the apical zone that you're going to be. We're talking about inspection now, so you're going to be with your eyeballs looking at this region for any pulses like that are coming with systole out of the skin. Then there is the right lower border, lower sternal border, the left lower sternal border. You're going to look in these regions. So those are the peristernal borders. Then you're going to jump up to the base of the heart. Really, the aortic and pulmonic areas are where you're looking. That's just called, we talked about that the last lecture, that's called the base. You'll be looking for pulsations there. Then you're going to be looking up here at the jugular notch. This whole region is called the sternoclavicular region. I like to call it the jugular notch region because really that's the only place you can see anything. And then the last place you look is down here by the xiphoid in the epigastric region. I can see the question, which one of the following areas is not part of the precordial region? So make sure you know all these regions. You could see abdominal aortic aneurysm, might see a visible pulsation in here. Got it? All right, you will inspect the following regions. Everything I just said. You'll inspect the apical region, which everything I just said is right here. The left lower peristernal areas. You might see some heaves, and we'll talk about heaves in a minute, but we're really looking for abnormal movements. Normally, here's a guy, there's his neck, there's his head, he's laying here on a table, and the chest is rising up and down. He doesn't have any arms, this guy. There's his hair, the nose. So the chest doesn't do anything except raise up and down. But sometimes you can see a little pulsation going over. It matches systole. And those are called heaves or thrusts. I think it's best to call them abnormal or precordial movements, but we'll just stay with heaves. We have slides on that. But that's what we're looking for. We're looking for abnormal movements that match systole when we inspect this region. Okay. Everything I just went over. Everything I just said. So precordial movement again, typically it's a quick flicker or a quick rise and then fall of a small area of tissue, usually in between. What's got to be in the between the ribs, the intercostal spaces. So. And it has to usually coincides with systole. There's three words for these precordial movements. Lifts and heaves. These two are definitely AKAs in our board books. There's some authors that think they can differentiate these. That's way beyond the scope of a run-of-the-mill examination. If you have special equipment, you might be able to. McGee goes into explaining the difference between these and then thruster in kids. But they all mean one thing. They mean that you can see a visible pulsation on the chest of somebody with your eyes. Or you can, maybe you can't see it, but you can feel it. You can palpate it with your fingers. Bates and Seidel use the word lift and heaves as AKAs for each other. Seidel uses the term thrust when he talks about kids. I think that might be just an accident, but nevertheless, these are the board books that we live by because we live to pass the boards, right? That's our function for this examination stuff. So lifts and heaves, I call them heaves, but you could call them lifts. Thrusts for kids. So what they indicate? Or what do they? Let me fix that slide. We'll probably get a bunch of these fix slides here. So number 14, fix. So what do these things indicate? Well, if you have a heave in the epigastric region or in the left lower peristernal region, that is where patients with right ventricular hypertrophy show up with heaves in these regions. This is definitely a high-yield slide right here, so make sure you know this stuff. A heave in the apical region, right? the fifth intercostal space, left, right in the left midclavicular line. That indicates left ventricular hypertrophy. Now we'll talk about the difference. You know, I forgot to explain MMI. No, I think I did. But so people with left ventricular hypertrophy may have a visible pulsation, a big pulsation in the apical region. And there's normally about a third of you have a pulsation, especially if you're really thin-chested. You'll have a visible pulsation there anyway. That doesn't mean you have left ventricular hypertrophy. We'll learn the difference between a normal apical impulse and the left ventricular hypertrophy type of a heave. I'll save that though. Carotid artery aneurysm, then you would have in the jugular notch region, you would have a visible pulsation. And it would be a big pulsation. It's normal. Some people, skinny, thin people, might have a little pulsation there. You could feel it there, but it shouldn't be a gigantic one. It shouldn't be a heave, which is a gigantic bulging of the skin every time systole occurs. Right, so make sure you know that slide. Apical impulses. So its magnitude gives us a good idea about the size of the left ventricle. In fact, when I went to school, we didn't even do this technique. Or we did it, but it was not relied on. We tried to percuss the borders of the heart. And research has proven that that's really a worthless technique. You can't accurately percuss the borders of the heart, not even the left border. But finding an apical impulse, if you're lucky enough to find one, gives us a good idea. There's good research on that. If you have a apical impulse that's about the size of a dime, about the size of your finger pad, and it's only in the fifth intercostal space, midclavicular line on the left, your heart has got a decent chance you don't have left ventricular hypertrophy. Right? The PMI, I should have made a slide on this. For next time, I'll do a PMI slide. So if you have a heave somewhere in the precordial region, that's going to be the PMI. So normally, if you have a visible apical impulse, that would be the PMI. If you can see a pulsation on your chest anywhere, that's the point of maximum impulse. And usually it's the same as the apical impulse if you can see one. However, people with, a big ventricular septal defect, they may have a PMI, a maximum medical improvement, a point of maximum impulse. That might be down on the right or left parasternal border. So in that case, and maybe they have a normal apical impulse, so they might have two pulsations on their chest. Well, the big one, the maximum impulse, or the point of maximum impulse, or the PMI, would be on wherever it is, the right or left parasternal border. So that would be a case where the PMI is not actually the same as the apical impulse. Okay, so that's always confusing. All right, the apical impulse is a quick flickering or uplifting of the intercostal tissue in the fifth intercostal space midclavicular line, on the left, of course. Did I add that? Add left to 16. Add left. Oops, add left. Yeah, and that's not, that would be the PMI if you don't see any other impulses. So that's good. The magnitude doesn't normally get big enough to be classified as a heave. Yeah, this slide's just messed up, as I said before. So that's just called the PMI. Even though the PMI would be here, you wouldn't classify this as a heave. All right, here's a nice drawing. So here is the apical impulse. This is usually the PMI as well. Now, some people with, let's say you had left ventricular or you had a intraventricular septal defect and you have blood gushing over and you're getting a big heave of the chest here with systole because blood is shooting over to the side of the heart. This might be visible, and that would be the PMI. What if both are visible? Well, if it's just a little flicker, and this is a big kind of big outpouching every time systole occurs, this would be the PMI. And this would be a case where this wouldn't be the PMI, but this would be a heave. This would be called a lower sternal border heave, or right lower sternal border heave. Okay? But the PMI, you need to memorize the location of the PMI. Apical impulse is measured as follows. So here's some, I'm not a big one with measurements, but I've been told that these measurements still live on the test, so you need to know these. Bates uses 8 centimeters, and then in another part of the book he uses 4 to 9 centimeters. So if you measure the mid-sternal line, and you take a tape measure and you measure out, we'll say 8 centimeters in the 5th intercostal space, not a very straight line there, that's your PMI, and that's where you would look for the apical impulse. Right? I got to stop saying PMI. PMI it's confusing. I wish they would get rid of it and just say, oh, I got a heave. That PMI is just a pain, but I've heard that is around. And where's the PMI in the chest? It's normally the apical impulse. If they have a heave, a left parasternal heave, then that's going to be the PMI, because a heave, by definition, is not a flicker. It's a significant kind of outpouching of the tissue. All right, so 7 to 9 centimeters left of the mid-sternal line in the 5th intercostal space, that's where the apical impulse lives. Another way to say it is the mid-clavicular line, 5th intercostal space, usually just a hair inside the mid-clavicular line. Make sure you know that. There should be a star. There will be as time goes by here. What is a normal apical impulse? It shouldn't be really wider than your finger pad, but it definitely shouldn't be wider than 2.5 centimeters. A quarter, I believe, is 2.4 centimeters. So it shouldn't be bigger than a quarter for sure. It definitely should not be wider than 1 intercostal space. You'll usually find it in the 5th intercostal space, unless the patient is really big. Maybe it's in the 4th, or maybe it's in the 6th, but it better only be in 1 intercostal space. If it's not, the patient has left ventricular hypertrophy. And that's not good, because that means their heart is being ruined, is already wrecked, probably by chronic hypertension, and they're not taking their blood pressure medication, or maybe they only take it when they go see doctors and then they stop taking it. So that's an important diagnosis is to find out when someone has left ventricular hypertrophy, because that could end the patient or shorten the patient's life significantly. If it's bigger than a quarter, they have left ventricular hypertrophy. If it has shifted, if you can feel it in 2 intercostal spaces, they have left ventricular hypertrophy. If it's shifted to the outside, if you can feel it out here, they have left ventricular hypertrophy. So those are 3 ways that they can have that you can diagnose left ventricular hypertrophy just by this PMI. The wild card is the darn thing is not there all the time. The books say it's there in a third of patients. I think it's more like 20% of patients. I feel a lot of these every quarter. No pun intended. But they're tough to find. I mean, if you're really worried about someone has left ventricular hypertrophy, what do? You send them to a cardiologist. Or if you want to go look a little further, you could order a soft tissue chest film and see what that looks like. Or you could order, what will the cardiologist do? He'll order a ultrasound of the heart, and you can tell how big it is, amongst a whole bunch of other stuff. How often is the apical impulse present? So with special tangential lighting, it's called, the board books say you can see it in 40% of adults. With regular room lighting, it's more like 20%. Okay. If you can't find the apical impulse to see if it's the size of your finger, you could use a special maneuver. I like this, the left lateral decubitus position. Star for you right there. Make sure that you know that. All you do is you push them on their with their left side down, but they're not like 90 degrees to the table. They're about 45 degrees. You have to hold them there. They should fall back to you. So that will increase your chances, they say, to 66%. I still don't get these kind of numbers. All right, but it helps. The only thing you have to be careful with the left lateral decubus position, you can't use the mid-clavicular line anymore, because now if you feel the pulse and it's right here, you can still use the size of it. It still better not be bigger than a quarter, but you can't use its position, because when you roll the patient like this, it pushes the heart over a little, and it'll be outside of the left midclavicular line. So that doesn't work anymore, but the size is still accurate. Got it? What does an abnormal apical impulse indicate? I said this already. If it's too big, it indicates left ventricular hypertrophy. How big is too big? Bigger than a quarter, bigger than 2.5 centimeters. If it's shifted to the left in a supine position, left of the midclavicular line, it indicates left ventricular hypertrophy. What if it's shifted to the right? What if it's right up against, what if it's getting close to the left parasternal border? So that's a right shift. So that could indicate right ventricular hypertrophy. That could indicate an ascending aorta, like a Stanford A aneurysm, or a pulmonary artery aneurysm. So a right shift is not good. In fact, it's probably more urgent than a left shift. So I like that. That's a perfect question, isn't it, for my 4 multiple choices with 4 questions, 4 answer choices? Right? Let's see. How could the question go? If the apical impulse shifts to the right, let's see. A right shifted apical impulse indicates all of the following except blank. Right ventricular hypertrophy, left ventricular hypertrophy, ascending aortic aneurysm, pulmonary artery aneurysm. What's the answer? Left ventricular hypertrophy. Those are how my questions, just exactly like the board's right questions. Non-pathological location. So in children, it may be palpated up in the 4th intercostal space. In tall people, it could be stretched out. It could be down in the 6th intercostal space. Pregnancy people, it could be pushed into the 4th intercostal space as well, and it might be lateral to the left. Can add left there, left midclavicular line. All right, so now let's get to palpation. A lot of palpation is kind of the same as what we're inspecting. There's only 2 things that we do, as I said, in palpation. We're going to search for thrills, which is turbulent blood flow, and then we are going to assess, not with our eyes this time, we're going to palpate the apical impulse. Search for thrills. So to search for thrills, you're going to search the precordium, and the best place to feel turbulent blood flow is actually the metacarpophalangeal joints. These things right here, metacarpophalangeals, but not the dorsum. You want the palmar surface. Okay, those are the most sensitive. So if it's a guy, you can use your full hand. If it's a girl, what are you going to do? You can only use this one. You have to do like a karate chop and search like that. And you can have them do a breast tissue pull, put their hand on their breast tissue and pull it toward that same side shoulder. And then you could go like that. I'll demonstrate. I'm going to try to do a lab video later today. Internet's moving super slow, so I probably won't get it uploaded till later tonight, but I've seen you guys are way behind watching these things anyway, so I don't think it'll make a difference. Okay, so that's searching for thrills. We're going to search the pericardium and all those places we talked about. Everything I said, if you're female, you have to use the medial part of your 5th metacarpophalangeal joint, like a karate chop, in order to avoid breast tissue. You could use the palmar surface of your 1st through 4th fingertips, but that's not recommended. There's been research on that, and they don't pick up vibration as good as your metacarpophalangeal joints do. Here again is the region. We're going to search all of these regions. We'll go right, boom, 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 right around the horn here. Search all those regions. So if I ask you on the in the practical, which I don't think we're going to probably have again, but if we do, I might say, okay, I want you to palpate. I'm not going to say search for thrills. I want you to palpate the precordial region. So you'll have to go, okay, I'm going to do the apical area. I'll do the left lower sternal border. I'm going to do the left base of the heart, or you can say the pulmonic auscultation area. I'm going to do the right base of the heart. I'm going to do the sternoclavicular region or jugular region, jugular notch region. And then I'm going to go down here, do the right lower parasternal border, and then I'm going to do the epigastric region. So that is a proper examination, palpatory examination. Looking for, no, not bruise. Turbulent blood flow, I want a better answer. Thrills, you're looking for thrills. Why use the metacarpophalangeal joint? Already said. There's research on that. It's more sensitive to vibratory sound. What are you palpating for? Said that already. Thrills. What are thrills? They're vibrations coming from the turbulent blood flow. They feel like you ever pet a cat? That should be pet. You ever pet a cat? Slide 30. And the cat starts purring. You can feel that vibration in your fingers. That's what a thrill feels like a purring cat. And remember, you auscultate for bruise, but you palpate for thrills. What causes palpable thrills in the precordium? This is a good slide. I put a star in this slide for you. So aortic stenosis, typically felt at pigs eat too much, in the right second intercostal space, parasternal border. If you feel a thrill here, if you feel a cat purring, it could be dangerous aortic stenosis. That's not a good diagnosis. An ASD, atrial septal defect. So that will present as a thrill in the right or sometimes the left lower parasternal border. Depends if Eisenmenger syndrome is going or not. We'll talk about that in class. How about a ventricular septal defect? Same. That could be in the left or right lower parasternal borders. And authors are all over the place. I'm using board books, right? Because authors don't agree on these locations. But for Seidel and Bates, they are pretty much on point. So next part of the palpatory exam is to find the apical impulse. So in first quarter, hopefully they're still making you learn to palpate the intercostal spaces. I guess I'll demonstrate that on my lab because I'm not sure if they're still doing that. They're probably not. Because I don't want you to count down. When I want you to palpate, I want you to jump right to where this is. And for girls, if they have a bra on, that wire, if you go right in the middle of that wire, right underneath, that's usually the apical impulse. So it's usually a pretty good marker in the midclavicular line. So that actually can help. All right, so that's what we're going to do. We're going to put the pad of one finger, not two fingers, one finger, and we're going to wiggle it around so we can find the intercostal space. And that's going to be the left fifth intercostal space, right? Just inside the midclavicular line. What does the apical impulse feel like? It feels like a small little tapping or a flickering when you feel it. And you can see it too in some people. You can see how it's just a really quick little flicker. And we said you have about a 33% chance of finding this in adult in a supine position. If you put the patient in the left lateral decubitus position, it's supposed to raise it up to 66%. But remember, I said that pushes the apical impulse laterally, so you can't assess position, but you can still assess the size of it. It shouldn't be bigger than a quarter. All right, and that's just the left lateral decubitus position again, everything we said. Abnormal findings in there. Oh, that should be and there. 1035. Again, sorry for this. Brand new slides. This is the first time I'm going through them right now, other than making them. And I make them with my Dragon Naturally Speaking. And so it's not the same as writing them. I can never type all this stuff. My hands would be destroyed if I tried to type all this stuff out. Good plug for Dragon. That Dragon 15 is, I can literally type about this speed as I'm talking with pretty darn good accuracy. It's amazing. Although my databases have years and years in my database, so it knows all the mistakes. And anyway, don't want to get off on that tangent. Exactly the same. So apical impulse. So assessing for an abnormal finding is the same for inspection. It shouldn't be bigger than 2.5 centimeters. It shouldn't be to the left of the midclavicular line. If it does, it indicates left ventricular hypertrophy. All right, now let's get to percussion. We only use percussion. It's like I seriously doubt if you'll ever be asked to percuss the precordial region, but you never know. When they say percuss they'll either say percuss the precordial region of the heart, or they'll say assess the borders of the heart via percussion. The right border you just can't get. You don't try that one. But the left border you're going to try for. McGee and Jarvis, they don't even talk about it. They just completely blank on it. Because they say the sensitivity and specificity are terrible. The positive likelihood ratio, which is the same as specificity, is 2.5. And it's literally worthless test. Seidel says the size of the left ventricle is best judged by the apical impulse, but he doesn't go on to describe it. Bates is the only one who talks about it. Bates says that you should always use the apical impulse to judge the size of the left ventricle, but he brings up a good point. What if you can't find it? Most people, you can't even find the darn thing, so you have to do something if you're out in the woods in Alaska. So if you're out in the woods in Alaska, you don't have an ultrasound, or you can't take a soft tissue film, or you don't have a cardiologist to refer to, this is all you got. So you start over in the mid-axillary line. And did I put that in there? So you start in the, it doesn't matter. You can start in the anterior axillary line, or you can start in one of the axillary lines. Let's say mid-axillary line. Yeah, I'm not going to. Mid-axillary line. And then you're going to percuss medially. Let me add that to my list. You're going to percuss medially down that intercostal space. And remember, what's the normal percussion note of the thorax? Resonant. So you're going to look for the resonant turning to dullness. In fact, that's called the cardiac dullness. And you take out your marking pen and you mark it. And then you go in the fifth intercostal space. You do the fourth, and then you repeat in the fourth intercostal space. Or whatever I said. Start in the fourth intercostal space, mark. Go to the fifth intercostal space, percuss immediately. Wait for that thud to occur. The trouble is you can't hear that thud very good. I mean, percussion, dullness, and resonance are very close together. It's not like assessing the border of the lower border of the liver where you're going from tympanic to dullness. That's a marked difference. You got a decent chance of hearing that. But anyway, after you've made the marks, get your tape measure and measure in the mid-sternal line where those marks are. If they're greater than 10.5 centimeters, you got yourself a patient with left ventricular hypertrophy. Simple as that. All right, we made it through. All right, so what else do I want to say to you? We have tomorrow, what do we have tomorrow? CVPP. Midterm, that's a big one, right? Make sure your notes are organized. I'm giving you all the time. You'll have 2 hours to take it. You people with special time will probably have 4 hours to take it. So no excuse for not doing well. You got plenty of time. I'll make it also so you can go backwards. Try that experiment with first quarter. I don't think it went so well, so I'll just leave that open for you. All right, see you later.